Dr. Rehn, you have published a paper on the efficacy of a two-tiered trauma team activation protocol in a Norwegian trauma hospital. Can you please tell us what is a two-tiered system for trauma team activation?
A two-tiered trauma team activation system is a system where you have a large trauma team consisting of many members and physicians and nurses, and you have a smaller trauma team consisting of fewer people, giving the large trauma team to those patients where you are quite certain that there is a need for a multidisciplinary high-resource resuscitation, whereas you provide the limited trauma team to those patients where you are quite uncertain.
So what would be the benefits of having a two-tiered system versus a one-size-fits-all?
I think the benefits of the two-tiered trauma team activation system is that you, first of all, you reduce the resource expenditure on overtriage. You have fewer people taken out of elective surgery for unnecessary trauma team activations. And further, you also reduce the threshold for activating the trauma team for the pre-hospital EMS providers. So if you work in an ambulance and you are uncertain whether this patient should be seen by a trauma team or not, you have a higher probability of activating the trauma team, and you know that it does not affect all elective surgery at the hospital.
Your study has now been published in the British Journal of Surgery. Can you please sum up the findings of your study?
Well, in general, we found that the amount of under-triage, which was quite high in our hospital, was significantly reduced after the introduction of this two-tiered system. And we also found that the amount of resource expenditure on over-triage was reduced, indicating that we have increased patient safety and reduced resource consumption.
Do you think that the results are transferable to other institutions or other hospitals?
I definitely think so, because Stavanger is a medium-sized Norwegian hospital, and it's quite unique because it has a trauma registry. And in general, at least in Scandinavia, the trauma registries are normally placed in the larger hospitals. So here we have data from a medium-sized hospital, and the majority of trauma hospitals in Scandinavia are medium-sized. So I think that this is definitely a strength for paper, and it increases its transportability.
Do you think it will have a general transferable meaning for hospitals and institutions outside Scandinavia as well?
Well, all systems are specific, and in Scandinavia we have climatic conditions which are quite unique compared to continental Europe. We also have a quite low amount of penetrating injuries, and we have a high amount of physicians working pre-hospitally. However, I think that the patients are, although more or less the same, and I think it's a bit up to each and every one to evaluate whether this study is relevant or not, but in general I think yes.
So what do you think are the limitations to the study?
The major limitation is that we introduced several factors at once, so it's a bit difficult to identify which of the interventions that were the most successful. So we introduced the new criteria for trauma team activation, new ambulance documentation system, a bit new way to evaluate patients, and also a two-tiered trauma team. So which of these interventions are the most yielding the most effect is a bit uncertain, and so that's a limitation. And another limitation is that we have no external control group. We control against ourselves.
The British Journal of Surgery offers open access publishing, and you have chosen this option for your study. Why is that?
Well, we chose to publish online open because it gives all colleagues worldwide access, regardless of financial status. And we know that the largest amount of trauma patients are seen by physicians working in low-income countries. And we think as a matter of collegiality, it's important to provide these colleagues with updated trauma science. And my employee, the Norwegian Air Ambulance Foundation, has this as a more or less policy. So that's why we chose to publish online open, and we're very happy that the BJS provides such a service.
Well, thank you, Dr. Rehn, and congratulations with your fine work in the BGS.
Thank you very much for having us.